Mycobacterial infections of skin. Mycobacterial infections can be divided into cutaneous TB or atypical mycobacterial infections. Atypical comes about swimming pool granuloma and Buruli ulcer. That's it. But cutaneous TB, that's also called extrapulmonary TB, can be true cutaneous TB or tuberculoids. So true cutaneous TB is direct invasion of skin, while tuberculids is hypersensitivity reaction to Mycobacterium tuberculosis. So true cutaneous TB, direct invasion, previous sensitization of host. Unsensitized host or sensitized host. Unsensitized host is primary TB chancre, undermined edge of ulcer, and secondary sensitized host bacterial load depending on that. Paucibacillarily means low bacterial load, multibacillary means high bacterial load. So in low bacterial load we have TB Verrucosa cutis or Lupus vulgaris. High bacterial load mode of acquisition, we have endogenous, autoinoculation, and hematogenous. Endogenous Scrofuloderma, autoinoculation orificial TB, and hematogenous TB gamma and miliary TB. So secondary cutaneous TB, which is when there is an infection of skin by TB bacterium in a previously sensitized host, that is secondary cutaneous TB. So in that again we have low bacteria and high bacteria. Low bacteria, first one is TB Verrucosa cutis, also known as warty TB, anatomist warts. Verrucosa meaning rough, uneven, warty surface. Root exogenous, skin lesions, indurated verrucous plaques. Site extremities. Lupus vulgaris. Lupus, it means wolf-beaten appearance. Most common cutaneous TB in adults is Lupus vulgaris. Roots exogenous and endogenous. Increased cell-mediated immunity. Paucibacillary form of the disease. Here you can see again bacterial load less, you have TB Verrucosa cutis and Lupus vulgaris. Lesion in Lupus vulgaris are annular infiltrated plaque, central atrophy and scarring, periphery advancing margins active, site extremities, buttocks, face. Investigation diascopy. Pressing a glass side on a lesion, you will see yellow-brown border color. Granulomatous lesions, apple jelly nodules. Yellow nodules, those are diagnostic of Lupus vulgaris. Differential diagnosis for apple jelly nodules. Lupus vulgaris, sarcoidosis, cutaneous leishmaniasis. Scrofuloderma, most common cutaneous TB in children. Decreased cell-mediated immunity, multibacillary form of disease. Again, we'll go to our table. So here, TB infection of the skin in a previously sensitized patient is called secondary TB, skin TB, depending on bacterial load. Low bacterial load causes TB Verrucosa cutis or Lupus vulgaris, which is most common. Or if there is high bacterial load, then depending on the mode of acquisition, If it's an endogenous infection, then it causes Scrofuloderma, which is the most common cause in children. Decreases cell-mediated immunity, multivascular form of disease. Pathogenesis, TB focus, endogenous, lymph node, bone, fascia, joints, direct invasion of the skin, painless subcutaneous nodules, ruptures into overlying skin, draining sinuses, undermined ulcer, fibrotic scars. And this is also what I have seen most commonly in OPD. Most common focus of infection is a cervical lymph node, healed scar with fibrosis. Site, neck and axilla, most commonly seen. Orificial TB, it is a multibacillary form of disease. Decreased cell-mediated immunity. Advanced internal TB, autoinoculation, site mucocutaneous junctions. Pulmonary TB happens at lip. Intestinal TB, perianal. Genitourinary TB, genital areas. Tuberculids, hypersensitivity response to multibacillary TB. Increased cell-mediated immunity. Mentuk's test positive. Classification based on morphology. Micropapular lichen Scrofulosorum. Papulonecrotic tuberculid. Nodular erythema induratum of Basin. Lichen Scrofulosorum. So all these lesions that you will be seeing are not infections, but actually they are hypersensitivity reactions. So lichen Scrofulosorum, let's see an example for that. This is how it looks like. Very dramatic nodules, many in number. Definitely something different than what you usually see. So that is lichen Scrofulosorum. Age group, children. Lesion, asymptomatic grouped lichenoid papules. Site, trunk. Histopathology, perifollicular non-caseating granuloma. Differential diagnosis, lichen nitidus. Nitidus meaning shiny. Common features, child asymptomatic papules identified by shiny lesions, localization, face, forearm, shaft of penis. So nitidus means shining. Let's see an example of that. Here, so these are shining papules. Lichen nitidus. Papulonecrotic tuberculid. Age, young adults. Lesion, papules with central necrosis. Site, lower extremities. Here is an example. Papule with central necrosis. That is papulonecrotic tuberculid. Easy to name. Papule with necrosis in the middle, and it's a tuberculid. Erythema induratum of Basin. Lobular paniculitis plus vasculitis. Paniculitis means inflammation of subcutaneous fat. Lesion, red tender nodule. Site, posterior aspect of leg. Fate, heals with scar. Erythema induratum of basin. Let's see. Erythema induratum of basin. Fancy name. This is how it looks like. It's tender. So whenever you see this kind of skin lesions, start thinking about TB. They heal with a scar. Drug differential diagnosis: erythema nodosum, red tender nodules. Site, anterior aspect of thigh. Heals without scar. So your erythema nodosum will heal without scar, while the TB tuberculids will heal with scar. So let's see how erythema nodosum looks. So it's similar looking, not a characteristic central necrosis, and there won't be any scar, and it happens on the shins. Treatment of cutaneous TB: anti-tubercular therapy, 6 months. HRZE for 2 months and HRE for 4 months. Cutaneous TB treatment: 6 month anti-tubercular drugs, HRZE for 2 months, HRE for 4 months. Atypical mycobacterial skin infections. Swimming pool granuloma. So also known as fish tank granuloma. Organism M. marinum. History: occupational exposure to contaminated water, fresh water, salt water. Nodular lymphangitis, suppurative nodules along lymphatics of extremity. Minocycline is the drug of choice. Differential diagnosis: sporotrichosis, nocardiosis, cutaneous leishmaniasis, tularemia, nodular lymphangitis. Burili ulcer, organism M. ulcerans. Pathogenesis: toxin mediated myclolectone, necrosis of tissue. Lesion: painless ulcer with undermined edges. Burili ulcer. Treatment: rifampicin plus clarithromycin. In clarithromycin intolerance, rifampicin plus injection streptomycin for 2 months. Buruli ulcer is very easy to identify after looking at this image. Coming to viral infections of the skin, very common. So 5 infections that we have to learn about: herpes, pox, human papilloma, entero, and parvo. Herpes are DNA viruses. Latency: lifelong persistent infections. So that is one thing why people are afraid of it, is that when you have a herpes infection, like along your lips or anywhere, then you have it for life. Herpes virus, orolabial herpes, also known as fever blister, cold sore. Herpes labialis. Grouped vesicle at lip margin. Tab acyclovir 400 mg 3 times a day for 5 days. Herpetic gingivostomatitis. Child presenting with high-grade fever. Lesions: vesicles rupture, erosions covered by a membrane. Herpetic vitiligo. Involves distal pulp of a finger, seen in dentists. Eczema herpeticum. Kaposi verrucoliform eruption. Overview. Herpes simplex virus 1 infection is disseminated cutaneous. Herpes that is seen in patient with eczema. Association atopic eczema, defective skin barrier, cutaneous T-cell lymphoma, especially Sézary syndrome, Darier's disease. Lesions umbilicated vesiculopustules rupture, multiple punched out erosions covered by hemorrhagic crusts. Treatment acyclovir mild oral or severe IV. Erythema multiforme, most common trigger herpes simplex virus 1. Lesions target lesions, 3 zones over extremities. Meningitis is called Mulleret meningitis. HSV2 genital herpes. And the one we were reading about, it was HSV1. So HSV1 is causing all these infections and HSV2 is causing genital herpes. Grouped vesicles, discrete tender ulcers. So this is a very differentiating factor. Ulcers are painful. They fuse into each other and coalesce and form polycystic erosions. Varicella zoster virus, primary infection, varicella chickenpox, then reactivates as shingles, which is very common here in Canada. They immunize old age people against shingles by giving the herpes zoster vaccine. Dewdrop over rose petal appearance. This is a chickenpox lesion. Varicella. Lesion vesicle over red base. Dewdrop on rose petal appearance. There was an outbreak of varicella recently. All the people coming in with this kind of lesions, and then you have to check if they are pleomorphic. That is, the vesicles should be at different stages. Like at one point it's fresh, then at other point they are already scabbed, stuff like that. So when they are at different period of infectivity, pleomorphic, then it's a diagnostic that it's chickenpox. Vesicle over red base, dewdrop on rose petal appearance, crusting of all the lesions, period of infectivity. So we did advise all these patients in the outbreak that once all your lesions have crusted over, then you can come back to work. Sequence appears in crops. First macule, papule, vesicle, pustule, scab. Pleomorphic rash specific to chickenpox. Like I told you, different morphologies of rash are present simultaneously. That is very characteristic when someone is coming in with itchy vesicle rashes. Period of infectivity till all the lesions have crusted, which is like 5 to 7 days after appearance of fever and stuff. Consequences of maternal infection. So as you know that this infection is not good when happening in pregnant women. That's why we immunize them before pregnancy with the consequences of maternal infection. Maternal infection less than 20 weeks of gestation. Presentation that is called congenital varicella. Less than 20 weeks in the formative stages. cutaneous dermatomal scar, limb atrophy. Neonatal is around the delivery. Disseminated vesicular rash, as they have shown here. Poor baby. Shingles, herpes zoster definition. Acute cutaneous segmental eruption. Pathogenesis. Infection by varicella. Latent virus in dorsal root ganglion, sensory. Exposure to risk factors like old age, HIV, lymphoreticular malignancies. Reactivation causes shingles and varicella zoster. Clinical features: fever, malaise, excruciating dermatomal burning pain, eruptive unilateral dermatomal, most common thoracic, painful grouped vesicles on red base. Complication post-herpetic neuralgia. Most disabling exhibits allodynia, non-painful stimulus perceived as painful, allodynia. Treatment: varicella and herpes zoster, 800 mg acyclovir, 5 times a day 7 days, or 1 gram valacyclovir 3 times a day for 7 days. Acyclovir is most commonly used. Treatment of post-herpetic neuralgia. Pregabalin gabapentin is most commonly used. Amitriptyline. Variants: herpes zoster ophthalmicus, herpes zoster oticus, Ramsay-Hunt syndrome. Justin Bieber had this. Nerve: trigeminal nerve, that is 6th nerve, frontal branch. Hutchinson signs of nose, that is rash and vesicle present on the side and tip of the nose. Then it's more probable that there will be involvement of cornea and eye due to common nose supply by nasociliary nerve. Herpes zoster ophthalmicus, painful condition. Investigation: Zank smear in HSV1, which was causing all the face related infections, 2, which was causing genital infection, varicella zoster virus. Multinucleated giant cells, classical, Zank smear. Herpes zoster oticus, Ramsay-Hunt syndrome, geniculate ganglia, facial nerve, that is the 7th nerve, and it causes lower motor nerve palsy, triad, otalgia, ear pain, vesicles in external auditory canal, herpes zoster oticus. Epstein-Barr virus, infectious mononucleosis, IEMN, glandular fever. Clinical features: there is a triad: fever, pharyngitis, posterior cervical lymphadenopathy. Triad. Drug reaction: ampicillin-induced maculopapular rash. So I just saw a patient who had these symptoms: fever, posterior cervical lymphadenopathy, missing pharyngitis, but that was the first doubt, like mononucleosis. But later it was chickenpox infection. Epstein-Barr virus. So that's the triad in that. Malignancies caused by Epstein-Barr virus: Burkitt's lymphoma, Hodgkin's lymphoma, nasopharyngeal carcinoma, oral hairy leukoplakia. I never liked this word. So it happens with HIV infected patient. Lesion: white corrugated rigid plaques. Site: lateral border of tongue. Character: cannot be rubbed off. Oral hairy leukoplakia. We will see and actually see if it looks hairy. and it happens in HIV patients on the side of their tongues. Here, this doesn't look hairy to me, that's why I don't like the name. Rigid plaques and white color. HHV infections. HHV infections, HHV5 disease, infective mononucleosis like infection, illness, inclusion owl eye inclusion bodies. HHV6 Roseola infantum, also called exanthum disease, sixth disease. Easy to remember. HHV6 causes sixth disease. And the full form of HHV is human herpes virus. So this is seen in children, fever plus maculopapular rash, uvulopatoglossal spots, Nagayama spots, red colored papules over the palate, human herpes virus 7 disease, pityriasis rosea. Diseases in human herpes virus 8 diseases, Kaposi sarcoma, multicentric Castleman's disease, primary effusion lymphoma. Multicentric Castleman's disease and primary effusion lymphoma, lymphoproliferative diseases. Kaposi sarcoma, multifocal vascular tumor, low-grade tumor, lesions purplish, violaceous, plaques, nodules, significance AIDS defining illness. Molluscum contagiosum, have seen some of this in the OPD. Definition: benign, self-limiting viral infection, keratinocytes. Term: molluscum, soft mollusk-like. Contagiosum, infectious. Etiology: pox virus, DNA virus. Molluscum contagiosum virus, MCV 1 and 2. 1 in children, affects the face. 2 in adults, anogenital sexually transmitted. The one actually which I saw was on the trunk. Lesion in the children. So there is a central pitting. Lesion: pearly white papules, centrally umbiculated, size 2 to 5 mm. Pseudocubnar phenomenon. New lesions along scratch lines due to autoinoculation, also seen in viral warts. Pseudocubnar phenomenon due to the scratching. Sexually active adults, immunosuppressed individuals. Lesions: giant lesions more than 1 cm. Atypical, extensive. Recalcitrant, non-responsive to treatment. HIV patients with molluscum contagiosum like skin lesion, skin only, disseminated molluscum, skin plus lung, disseminated histoplasmosis, skin plus CNS meningitis involvement, disseminated cryptococcus. So these are the conditions which you should think about when a HIV patient presents with molluscum. Complication: secondary infection due to scratching. Conjunctivitis, superficial punctate keratitis in eyelid molluscum. Investigation: cup-shaped invagination of epidermis into dermis, Henderson-Peterson body, eosinophilic intracytoplasmic bodies. Treatment: can be self-limiting. Physical method: curettage, cryotherapy, topical imiquimod, toll-like receptor 7 agonist. Parapox virus disease depends upon primary host. Host could be sheep or cow. Virus, ORF virus, pseudo cowpox virus. Disease, Ecthyma contagiosum, milker's nodule. Ecthyma gangrenosum is seen in Pseudomonas. Human papilloma virus, DNA virus. Tropism for squamous epithelium. Warts. Definition: benign proliferation of skin induced by human papilloma virus. Classification: genital, condyloma acuminata pointed, non-genital warts, varicula vulgaris. Etiology: HPV 2, 4, 27, transmission skin to skin, lesion asymptomatic, well circumscribed papules, plaques with variculous rough surface. It's a very ugly looking kind of lesion, and you just have to do cryotherapy. Keep doing cryotherapy until it's gone. Plantar warts, you will also use a scalpel and debrided. Warts with a plain flat surface. Etiology: HPV 3 and 10, plantar warts. Superficial mosaic warts, deep, myrmecia. We call it kani in Gujarati. It's very painful. Plantar warts, superficial, HPV 2, myrmecia, HPV 1. Differential diagnosis of myrmecia, corn. Due to HPV 1, it's myrmecia, and corn, excess build of stratum corneum due to increased pressure. Tenderness in lateral pressure, myrmecia. Tenderness in vertical pressure, corn. Filiform wart. Periungual warts, difficult to treat. Treatments: cryotherapy. This is a very commonly used instrument. It's called cryogun, and you feel liquid nitrogen in it, and then there are various attachments, and you spray the nitrogen on the lesion. Topical: salicylic acid, physical electrocautery, burn the wart, or cryotherapy. Liquid nitrogen at minus 196 degrees Celsius freezes wart. Epidermodysplasia verruciformis. Inheritance: autosomal recessive. Etiology: HPV 5 and 8. Lesions: face, plantar warts, trunk. How can there be plantar warts on face? Okay, so on face there is planar warts, sorry, and trunk there is pityriasis, versicolor like lesions, hypopigmented macules. Complication is squamous cell carcinoma. Enterovirus, hand, foot, mouth disease. So very commonly seen in OPD. It's in children basically, and you just have to wear gloves and mask while being with them. It's very contagious. Self-limiting disease. Hand, foot, mouth disease. Coxsackie A16 virus. Enterovirus 71. Lesion: papulovascular lesions. Distribution: palms, soles, buttock, oral cavity, anterior position. So it says here hand, foot, mouth. Herpangina. Etiology: Coxsackie A1 to A6, A8, A10. Enterovirus 71. Symptoms: high grade fever, painful papulovascular ulcerative rash, lesion, and posterior oropharynx. Well, this was anterior oropharynx. Hand, foot, mouth, and this is posterior herpangina. No skin lesions. Well, there are skin lesions in hand, foot, mouth, but Herpangina only loves the mouth. Parvovirus, so look at this cute baby here. Slapped cheek appearance, malar rash, reticular rash, erythema infectiosum, fifth disease. There was sixth disease that was caused by herpes simplex virus type 6. Here there is a fifth disease caused by parvovirus B19. It happens in healthy children. Symptoms: fever, erythema over malar area that spares the nasal bridge, slapped cheek appearance, reticulate lacy rash over trunk, net-like. Papular purpuric gloves and socks syndrome. Hand and feet erythema plus edema associated with Petechiae purpura. Moving on to fungal infections of the skin. Superficial mycosis. Definition: fungal infections of superficial skin layer, stratum corneum. Diseases: pityriasis versicolor, tinea nigra, piedra, candida, dermatophytosis. Pityriasis versicolor. Etiology: Malassezia globosa, more than furfur. Clinical features: morphology, scaly, pityriasis, perifollicular macules. Scales, fine, briny, furfuraceous, variety of colors, versicolor. Hypopigmented most common, or it could be hyperpigmented. Site: face, trunk most common. Scales: scratch test, Besnier's test, fine scale, scratch with nails, prominent scales. Hypopigmented lesion: Malassezia furfur produces azelaic acid, inhibits tyrosinase. Hyperpigmented lesions mechanism: fungus induces formation of larger melanosomes. Investigations: 10% KOH mount dissolves keratin, round spores, meatball, short hive pea, spaghetti. Spaghetti and meatball appearance. On Woodlamp's exam, yellow fluorescence. Treatment: antifungals used, azoles, selenium sulfide, antifungal with cytostatic properties. Antifungals not used, griseofulvin, oral terbinafine. Tinea nigra and piedra. Tinea nigra, fungal agent, Hortatia wernicki. Clinical features: asymptomatic hyperpigmented macules over palm. Treatment: topical azoles. Let's see this Tinea nigra. Tinea nigra. Here, dark lesions on the palm like this. Definition: superficial fungal infections targeting the hair shaft. Types: black piedra, white piedra. Etiology: Piedraria horte, Trichosporum beigeli. Nodules: black color, hard consistency, tight attachment to hair shaft, black piedra. White piedra, white color, soft consistency, loose attachment to hair shaft. Appearance: treatment: clipping of hair, topical azoles. Mucocutaneous candidiasis. So nigra means black. Fungal agent is Hortea wernicki. Clinical features: asymptomatic hyperpigmented macule over palm. Treatment: topical azoles. Piedra. Black piedra, black in color, hard consistency, tight attachment, White Piedra, white in color, soft consistencies, loose attachment, clipping or hair, topical azoles, mucocutaneous candidiasis, etiological agents, Candida albicans, oral candidiasis, white plaques, pseudomembrane candidiasis, oral thrush. Lesions can be rubbed off with a spatula. Chronic hyperplastic candidiasis, pseudomembranous candidiasis, red plaques, atrophic, acute form known as antibiotic sore tongue due to usage of antibiotics. Whenever you give antibiotics to patients, then some of them develop this painful red sores, and they will even tell you that this is because of the antibiotic. So it's that antibiotic sore tongue. Chronic form, also known as denture mouth, due to use of dentures. Candidal intertricho, in between thighs, tricho, folds. Definition: candidal infections involving the skin folds. Predisposing factors: moisture and friction, satellite pustules, macerated red plaque. Lesion morphology: macerated red plaque associated with peripheral satellite lesions, pustules, side groin and neck folds. It's itchy. Candidial balanophostaitis, radial fissures, balano glands prosthitis, prepuce inflammation. Lesion radial fissures, association DM. Candidial paronychia, predisposition, occupational exposure to wetness and detergents. Lesion, swelling of nail fold, loss of cuticle. Investigation: KOH mount, budding yeast cells, pseudohyphae. Seborrhoeic agar, creamy white colonies. Treatment: fluconazole. Dermatophytosis. Definition: superficial fungal infections that involve keratinized tissue. Fungi, keratinophilic genera. Skin, hair and nail. Microsporum, epidermophyton, trichophyton. So skin, hair and nail, all three fungi affect skin, and then you just have to remember that micro doesn't infect nail and epidermo doesn't infect hair. So micro doesn't infect nail and epidermo doesn't infect hair. That's all you have to remember. Pathogenesis: addition to superficial skin and tissue, invasion, growth into stratum corneum, generation of an immune response. Region-wise types: tinea capitis, involvement of scalp. Types: tinea capitis, non-inflammatory form, causes non-scarring alopecia. Black dot endothrix, grey patch ectothrix. Inside of hair affected, hair breakage, black dots. Etiology: tinea tonsurans, tinea violaceum. Black dot endothrix. Itchy scaly lesions with patchy alopecia, etiology M. canis. Grey patch ectothrix. Tinea capitis, inflammatory, causes scarring alopecia, favus. Etiology: tinea scoelinelli. Endemic to Kashmir. Yellow color cupped shaped crust, scutula. Kirion, boggy swellings. Etiology: tinea mentagrophytes, tinea verrucosum. Zoophilic fungi. Clinical features: history of contact with pet animal. Children, boggy scalp, swelling, kirion, easily pluckable hair, regional enlargement of lymph nodes. Investigation: KOH mount. One of my school classmate got this infection, tinea capitis, and she lost all her hair. and then it grew again in couple of months. So like one of the standards, she was bald, and so it's a non-scarring alopecia and it grows again. Tinea corporis, cruris, etiology, Tinea mentagrophytes, Tinea rubrum, lesion, annular plaque, central clear, itchy, periphery raised and scaly, site glabrous, non-hairy, skin except palms, groins and soles. Groin tinea cruris known as jock dovich. Onychomycosis, fungal infection of nail unit. Clinical features, nail plate color yellow. Subungual hyperkeratosis, pith absent. Distal lateral subungual onychomycosis. Most common clinical type, distal lateral subungual onychomycosis. Tinea in other regions, face, Tinea facie, beard, Tinea barbi, palms, Tinea manum, feet, Tinea pedis, also known as athlete's foot. Most common site is fourth toe web space. Tinea incognito, not recognizable, steroid modified tinea, changes in lesion on application of steroids, no resemblance to classical presentation, itch reduced, active margin lost, scaling diffuse. Investigation, 10% KOH mount, refractile branching hyphae. Treatment in tinea capitis, overall drug of choice is cresiofulvin, secondary to trichophyton, terbinafine. Topical agents, azoles. Mechanism of action, inhibition of 14 alpha demethylase, reduced ergosterol. Lenosterol does not change to ergosterol. Luliconazole, ketoconazole, miconazole, cotrimazole. Allylamines. Mechanism of action, inhibition of squalene epoxidase. For example, terbinafine. Systemic drugs, treatment duration of 4 to 6 weeks. Drugs used, itraconazole 100 mg BD, terbinafine 250 mg OD, fluconazole. In dermatophytic onychomycosis, terbinafine 250 mg OD. Fingernails 6 weeks, toenails 12 weeks. Itraconazole 1 pulse 200 mg 2 times a day for 1 week per month. Fingernails 2 pulses, toenails 3 pulses. Nail lacquer, topical nail paint. So this is very commonly used in Canada, nail lacquer, topical nail paint. So let's see what drugs are there in there. Amorolfine 5%, cyclopyroxolamine 8%, and terbinafine. So the brand name for this is nail polish for most commonly. And Jublia, let's read about it. It has efinaconazole 10% topical solution. Toenail fungus, change in shape, loosening, thickening, discoloration, brittleness, crumbling. Jublia, efinaconazole. So this is what is most commonly prescribed here in Canada, and it's actually not given in the list here. Okay, So where were we? Nail lacquer. In Canada, most commonly prescribed is Jublia, which is efinaconazole. But in our notes, we have amorphil, cyclopyroxalamine, and terbinafine. Subcutaneous mycosis, implantation mycosis, characterized by traumatic inoculation of fungus into skin. Sporotrichosis, rose gardener's disease. Etiological agent, Sporothrix shanki. Dimorphic fungus, lymphatics of extremities, lesion among lymphatics. Dimorphic fungus. Lymphatics of clinical features, history of thorn pick, usually in a gardener. Lesions, nodulo-ulcerative, proximal extension, linear lesions along lymphatics of extremity. This is commonly seen. Differential diagnosis for sporotrichoid lesions, nodular lymphangitis, nocariosis, atypical mycobacterium infection, swimming pool granuloma, cutaneous leishmaniasis, tularemia. Histopathology, asteroid bodies, central basophilic yeast, radiating eosinophilic material. Treatment, cutaneous sporotrichosis, CNS sporotrichosis. Cutaneous sporotrichosis, you give itraconazole, saturated solution of potassium iodide. CNS sporotrichosis, you give amphotericin B. Chromoblastomycosis, varicose dermatitis. Chromo, color pigmented fungi. Varicose, rough uneven surface. Etiological agent, pigmented fungi, dermatitious fungi due to presence of melanin in cell wall, presence in the soil. Species, Fonsia compactum, Phyalophora species. Clinical features, farmer with vegetative trauma, lesions, varicose plaque, slow growing, black dots on the surface, cauliflower like lesions, site extremities, trauma prone areas. So then you think about varicose dermatitis, chromoblastomycosis. Investigation, 10% KOH mount, round, brown, pigment, thick walled bodies known as medlar bodies, sclerotic bodies, copper penny bodies. KOH mount in chromoblastomycosis. Treatment, itraconazole. Mycetoma, definition, chronic suppurative granulomatous disease. Etiological classification, fungi, Eumycetoma, bacteria, actinomycetoma. Eumycetoma medulla grisi, medulla mycetomatis. Actinomycetoma, actinomedullae, and Nocardia brasiliensis, Streptomyces species. Clinical feature, men, seen in men more than women, seen in agricultural worker with penetrating trauma. Site, foot is the most common site. Triad, tumefaction, tumor-like swelling, granules from sinuses, multiple discharging sinuses, granules, colonies of the microbe. Black eumycetoma, pale cream white actinomycetoma. Sinuses, granules, swelling. I have seen this in beggars a lot. Mycetoma and actinomycetoma. Investigations, gram-negative septae hyphae 2 to 5 micrometer, gram-positive filaments. Histopathology, granules surrounding by suppurative granuloma, neutrophilic infiltrate, granules surrounded by homogeneous eosinophilic material. Treatment, antifungals, Wells regimen, cotrimoxazole and amikacin. Wells regimen in actinomycetoma, cotrimoxazole, and amikacin. So that's all, and parasitic infections are covered in a separate video. So keep watching.